Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is part 2 of Veno-Venous extracorporeal membrane oxygenation, and this will supply a little bit more information in an overview which is extra to the introduction. The objectives for this session basically are to review Veno-Venous extracorporeal life support, therefore ecmo, extracorporeal membrane oxygenation, the indications for it, the benefits, risks and complications associated, and contraindications. So, what then is ecmo? We asked this question previously. Realistically, it's a palliative rescue therapy, not a treatment, not a cure. But it lets the heart or lung or both have a vacation. It replaces and rests. It replaces and rests heart or lung function. And it's typically used for refractory failure, which means not responding to conventional interventions, but may be potentially reversible if treated. This is ecmo, extracorporeal membrane oxygenation in a critical care setting. So what then is Veno-Venous extracorporeal membrane oxygen therapy? Well, it's a therapy with an objective to bypass the lung, remove venous blood from the body, don't let it go to the lung. This blood is desaturated and hypercarbic, low in oxygen, high in carbon dioxide. Then we circulate the entire cardiac output through the membrane oxygenator, which can result in about 30 to 90% of cardiac output being directed to that gas exchanger. And then we return the theoretical arterial blood, which is really just resaturated, reoxygenated, decreased in carbon dioxide, blood to the body. It's resaturated and eucarbic. So therefore, what we have are cannulas inserted into two large veins. Could be the femoral vein, or it could be a subclavian vein in the femoral vein. Could be a jugular vein. But desaturation blood is removed or directed to the gas exchanger. Then it's allowed to be oxygenated with carbon dioxide being removed, as would be happening in the lungs, and then redirected back into the body, resaturated with a normal PaO2, PaCO2 and an SaO2. This is Veno-Venous ecmo therapy. With Veno-Venous ecmo, if it's peripheral cannulation, the jugular and femoral veins are cannulated. Looking here, the jugular, and the cannula sits just at the venocaval junction. The femoral cannula sits at the venocaval junction, inferior venocaval junction, and blood is taken out by the jugular, directed to the pump and returned to the femoral. This is cava atrial flow. So the objective is desaturated blood is removed, sent to the gas exchanger, and the blood is resaturated and returned to the body. The gas exchanger replaces the function of the lungs. Now, the potential indications for Veno-Venous ecmo or extracorporeal life support are acute respiratory distress syndrome, severe pneumonia, swine flu, MERS corona, COVID-19, aspiration pneumonitis, status asthmaticus, smoke inhalation, pulmonary contusion, severe air leak syndromes, pneumothorax, for example, TRALI, transfusion-related acute lung injuries, idiopathic pulmonary fibrosis, bridge to lung transplant, and primary graft dysfunction. When we look at intermittent positive pressure ventilation, this can cause ventilator-induced lung injury. It's a biochemical injury because it causes shear forces, over-distension, stretch due to intrathoracic pressure being increased. You've also got something referred to as the oxygenation index, which is used to assess ventilator-induced lung injury or ventilator-associated lung injury, VALI. And the physician will be looking at the PaO2 and the FiO2 ratio. They look at hypercarbic respiratory acidosis, airway pressures, excessive ventilation requirements which are occurring with ventilator-induced lung injury, and they use what is called the Murray score. And the Murray score should be greater than 3 if there's a problem. This is an example of the Murray score for acute lung injury. So therefore everything scores. I'm not going to go through it in any great detail, but you've got the chest X-ray score, a hypoxemia score, a PEEP score in centimetres of water when receiving intermittent positive pressure ventilation, and respiratory system compliance score, which is measured in mils per centimetre of water. The final score is attained by dividing the values obtained from the initial analysis by the number of elements used for the analysis. When the score value is 0, there's no lung injury. From 1 to 2.5, lung injury is considered to be mild to moderate, and when greater than 2.5, the diagnosis of ARDS is established. This is the Murray score for acute lung injury. Here are just some examples of chest X-rays to show you what we're talking about. Acute respiratory distress syndrome as a result of either swine flu or MERS corona A virus. MERS is Middle Eastern Respiratory Syndrome related to corona A virus. Then you've got severe pneumonia. This is right, middle and lower lobe pneumonia. If you're interested in chest X-rays, have a look at the Dr. Manny Learn Shops on chest X-rays. You'll learn a lot. You've got aspiration pneumonitis in the right middle lobe and lower lobe. You've got here severe air leak syndromes. Well, what you're looking at here is bilateral pneumothoraces. Both lungs are completely collapsed. Then you've got idiopathic pulmonary fibrosis, and essentially this patient needs a lung transplant. So it's a bridge to lung transplant. Then you've got TRALI, transfusion-related acute lung injury. Pulmonary contusion. So what are the benefits of VV extracorporeal life support or extracorporeal membrane oxygenation? It rests the lung, reduces the risk of ventilator-associated lung injury or ventilator-induced lung injury and the risk of oxygen toxicity. Venous cannulation. You use percutaneous insertion techniques. No arterial cannulation occurs. It's Veno-Venous. Shorter cannulation times, decreased risk of cerebral reperfusion injury. This decreased risk of direct lung injury from hypoperfusion. Oxygenated blood is delivered to the heart and the aortic root. There's no cardiac support required. And if it is required, none available. There are less hemodynamic consequences, and you're less likely to have severe embolic consequences, which is essentially stroke. The circuit longevity is due to lower circuit pressures. What are some of the risks? Infection, hemorrhage, hemolysis, stress ulcer development, thrombocytopenia as a result of HITS, heparin-induced thrombotic thrombocytopenia syndrome. You can get vein collapse, decannulation, displacement of the cannula, air embolism, circuit rupture, pump failure, gas exchanger and oxygen failure, local recirculation, and cardiac arrest. So the absolute contraindications, no questions asked, for all forms of extracorporeal life support, extracorporeal membrane oxygenation are if you are greater than ages 65 to 75, weigh less than 20 kilos, weigh more than 140 kilos. You've got non-recoverable respiratory disease, non-recoverable cardiac disease, either which here you're a non-cardiac or respiratory transplant candidate. There's non-reversible neurological disease, you've got chronic pulmonary hypertension, you've got active malignancy, graft-host disease and significant immunosuppression is one of your issues, advanced liver disease, or you could be 30 days post-vital organ transplant, or you had an unwitnessed cardiac arrest with CPR for more than 60 minutes. Here are some examples. Chronic severe pulmonary hypertension with a mean pulmonary artery pressure of more than 50 millimeters of mercury, they have pulmonary hypertension. Severe right heart failure, left ventricular failure, biventricular failure. The relative contraindications for Veno-Venous ECLEX or ECMO, multi-trauma with multiple bleeding sites, multi-organ failure, central nervous system injury, CPR for greater than 60 minutes. Because it depends on the outcome. So in summary, Veno-Venous ECMO or extracorporeal life support is not a treatment, it's not a cure, it essentially is a vacation and replaces or arrests lung function. For lungs, refractory and not responding to conventional interventions, but they may be potentially reversible. Thanks again, everybody. I hope you enjoyed part 2 to extracorporeal membrane oxygenation. Remember, there's another 12 possibly coming. So go and look for part 3 in ECMO and recommend it to your critical care colleagues if you think it's of any value, and subscribe. Cheers for now.